Well, very many thanks. And it really is a pleasure to be here. But the most important person who's actually joining us is Millie. And we'll be really looking forward to talking with Millie in due course. But let me just say a tiny word of introduction about myself. So I'm based at Imperial College London. And until I retired, which was in September last year, I had the incredible pleasure of working with many really gifted colleagues at St Mary's Hospital in Paddington, not the least of whom were the family HIV team. So the family team, this was them in about 2019. We worked together for 27 years, obviously with people coming and going. And also I had the pleasure of working with an amazing group of pediatric infectious disease consultant colleagues. And I show this slide because the HIV team, and indeed our family team that looked after children with hepatitis B and hepatitis C, had the massive advantage of really good diagnostics and very good molecular tools for monitoring disease. So for HIV, for these bloodborne viruses, HIV, hepatitis B, hepatitis C, we could measure exactly how much virus there was in the circulation. But of course, Borrelia is not a bloodborne virus. This is a bacteria that has incredible ability to hide away from our immune system, as does its cousin syphilis, another spirochete infection. And frankly, the diagnostics and the ability to monitor disease are woefully poor. And if I can achieve anything at all tonight, it is to really inspire the next generation, my colleagues in healthcare, to really think about this and to hopefully shed better science than I was able to bring to bear during my career. I got involved in looking after children with tick-borne infection really towards the end of my career, and if I was starting over, I would be looking at it with much greater determination to really advance the science myself. But in that regard, I want to pay immediate credit to Dr. Anne Cruikshank and all of the colleagues who I got to know through the Royal College of GP's Spotlight project on Lyme. And there's still the Lyme disease toolkit up on the RCGP website, which has got some very useful information, and I really recommend that to you. But also, it reminds me to say that last week on the 15th of March, there was a really excellent webinar that Zara Hussain and Jack put together. And I really do encourage you, if you weren't part of that, to go back and have a look at it, because obviously I'm not going to repeat all the things that Zara said, but she gave a really good overview of Lyme disease, some of the important clinical and diagnostic and treatment guidance. So without further ado, I want to anchor this talk this evening around a tale of two two-year-olds and a teenager. We've already mentioned the teenager, Millie. We'll get to her. But in the meantime, I thought in a fairly discursive way, I'd tell you about a couple of patients that came to my attention. So let me tell you first of all about case E. E was obviously the first letter of her Christian name. So this family lived near Puddletown in Dorset, and the original referral came via the Puddletown surgery. So in May 2019, when E was 2 years of age, her mum found a tick embedded in her forearm, and she removed it intact. Now, let's just stop there, because when I first started getting these referrals and learning a bit more about Lyme disease, I had no idea what a tick looked like. I would have assumed that this child was trying to stuff a raisin into her skin, and would have been not very much help at all. And to be able to remove a tick intact requires some knowledge. And I immediately want to pay tribute to the Lyme Disease UK support organization, because they've produced a really nice awareness pack for schools and children. And one of the things I really like about this is the idea that if we start educating children, they can start educating all the adults around them, a bit like that girl who was on the beach in Thailand or Sri Lanka, who recognized that as all the water was disappearing from the bay, that was the moment to start running for the trees because there was a tsunami coming. And actually, maybe that's exactly what is coming in our direction in terms of what tick populations are going to do in years to come. So I really like this idea of educating children, but also educating the adults around them, particularly those who are involved in special interest groups like the Duke of Edinburgh Award and other outdoors activities. One of the things they've produced is a tick kit, and it's got you can read there the components. It says sealable plastic bag to save the tick for testing. I'll come back to that. But there's lots and lots of really enjoyable, interesting advice. So tick removal, the basics are: do not use any funky stuff like petroleum, like Vaseline, hot match heads, all sorts of things you may have heard might be helpful. You need to use thin-tipped tweezers or a tick removal device and get the tick as close as possible to the skin as you can and pull it straight upwards, and don't tug it or rupture the body if you can possibly help it, and then disinfect the bite area. And I feel, if you'll bear with me, I actually really like this, and I'm grateful to Anne for sharing it with me. But this is just how the tick twisters work and how you can, well, I learned from this, so let me share this. Terrific. Yeah, so fantastic beats and where to find them. The ticks, as you're aware, their bites are painless. They really like moist, protected areas in the body. That's where they migrate to and where they feed. And they can continue feeding for days if they're not disturbed. And there is some evidence that the longer the attachment, the greater the risk of disease. But they can be really tiny and really difficult to spot. And so this is a really lovely close-up of genes showing you how tiny the nymphs are if you've been sitting around on the ground in a new forest for any length of time. Is it worth sending the ticks for analysis? I think this is worth thinking about, and certainly my colleagues at Porton Down do not offer, which is the national reference lab for tick-borne infection here in the UK, do not encourage people to send them ticks. There are some private organisations that will do tick testing, but if the tick shows that the tick contains pathogens, that doesn't necessarily mean that you've been infected. If you have been infected, you'll probably develop the symptoms before you get the results of the tick test, and you certainly shouldn't be waiting for the tick test results if you're getting symptoms before beginning treatment. And negative results may lead to false assurance. And to be absolutely frank, one of the things that I have thought about a lot and learned over the years is that we probably don't even know all the pathogens that are potentially tick-borne pathogens of humans here in the UK. So we may not even be able to test for them at the moment. So much more importantly, I mean, clearly you need to know what to do about removing the tick, but I'll come back to it. It's by no means every person who has a tick is going to get some form of tick-borne infection. So what symptoms should parents be watching out for? And one of the first things I would say is that if a child develops what seem to be flu-like symptoms, headache, feeling rotten, not wanting to play, not their usual self, lost their appetite, unusually fatigued in the middle of summer, maybe with fever, maybe not with particularly high fever, think about Lyme disease, because that's clearly unusual. Of course, actually, the COVID pandemic and all of the behavioral change of the human population has led to some pretty weird things going on. I mean, we were seeing respiratory viruses that we don't normally see outside the winter last year in the middle of summer, and certainly when the schools went back in September. So these are not hard and fast rules, but if it comes out of the blue, and if this year is a more normal year, which I sincerely hope it will be, then summer influenza symptoms really need us to sit up and think. And then obviously the erythema migrans rash, and Zara spent a lot of time talking about this last time, but I'll illustrate it as well. Facial nerve palsy, there was a very nice study published in 2020 from colleagues at Southampton, who obviously their catchment area is the New Forest, and they had a case series from 2010 to 2017, about 93 kids. Not everyone had been tested, but the vast majority were tested for Lyme disease, and 29% had positive serology. And of course, there may be actually a higher prevalence, because if the facial nerve palsy came on pretty quickly, it's just possible that the children hadn't got an antibody response by that stage. And then obviously there are other neurological manifestations, and there's going to be a whole session on neuroborreliosis next week. And so please do join that. But children can clearly present with headache and with neck stiffness and look as though they've got meningitis or meningism. And then joint stiffness can occur relatively early in my experience, and less commonly frank arthritis, meaning that the joints are actually swollen and hot and tender and painful. And then there are cardiac manifestations to think about, which in children are going to be very subtle presentations in young kids, really easy to mistake for something else. A child who suddenly gets sweaty and pale and may or may not complain of chest pain. And untreated, there is an absolutely extraordinary range of potential long-term symptoms, a bit akin to long COVID. So let's go back to our 2-year-old. So she's got the tick removed, and 2 weeks later, she got a ring-like rash on her forearm, and it faded within 48 hours. Mum didn't actually take a picture of that rash, and she didn't seek medical advice because she really wasn't that bothered. It wasn't, and the child seemed well at that time. But 2 weeks after that, this multiple rash appeared. This is a sequential photographs over a few days, and it was changing. It was coming and going. It was in multiple sites. They weren't classic bullseye lesions, and I think that's very typical, that it's more of a ring-like amorphous lesion, and it was accompanied by systemic problems. The child had reduced appetite, was not so energetic. There was no facial nerve weakness. There was no obvious joint involvement, but this was undoubtedly early disseminated disease. And the GP referred to the local hospital, where a very sensible district general pediatrician suspected Lyme disease, obtained a blood sample and sent that, but didn't delay, quite rightly, starting treatment with high dose amoxicillin. And that's one of the messages for tonight, is that 30 milligrams per kilogram per dose 3 times a day is a massive dose of amoxicillin. So many GPs, many primary care colleagues really balk when they do the sums, and they think, these nice guidelines must have got that wrong. And the answer is no, it really does mean it. You need to read the guidelines carefully and calculate that dose, because it's much bigger than you would expect. Obviously, you can round it up and down for the kids who are no longer needing suspension and who can take amoxicillin capsules. The results, interestingly, were already positive, but bear in mind this was at least 4 weeks after the original tick attachment, and so that's the sort of time when the antibody test may begin to become positive, 4 to 6 weeks after exposure, not before. And indeed, the confirmatory immunoblot that was done at Porton Down was unquestionably positive, with both IgM and IgG bands. So they treated the child with 21 days, which in fact, this girl took pretty well. But then in August, so another couple of months later, she redeveloped fever, loss of appetite, sweating, seemed to have some discomfort in her joints. And although she didn't have frank arthritis or CNS involvement or heart involvement, there was no other explanation for this. The consultant at the district general hospital ran a few tests, which you can see there, and consulted with me, and we agreed to treat her for another 17 days at that point, according to the NICE guidance anyway, with azithromycin, and she tolerated that and actually recovered uneventfully, which could have been the end of the story. But in May 2021, I got a call from the family, and they had a lovely Springer Spaniel who was spent his life rooting around in the undergrowth and chasing deer, which were all in the neighborhood. And he was bringing home a number of ticks every day. And just to remind you, the ticks really love it in both wooded, but on the edge of woods, heathland, moorland. You don't even have to have trees to have ticks, and long grass. And this, I love this picture. This is a picture of the so-called questing nymph, which has made its way to the end of the grass. And you can see it's like this nymph has got outstretched arms waiting for a mammal to pass by. And if that mammal happens to be human, it's going to attach at the sort of height of, depending on how high the grass is, of how tall the human is. And so children very often end up with ticks being attached above the waist, even in the hairline, and very, very easy to miss, not in the places that most adults will tend to have ticks attached. And so we really do need to be vigilant about looking at them. But the dogs themselves are brilliant probes for tick populations in the UK. And that led to this so-called the Big Tick Project, which you can see was published 5 years ago now. And this involved a whole load of veterinary practices. I mean, obviously there's a veterinary interest here because amongst the drug companies, because dogs also may have some forms of tick-borne infection. And these practices were asked to send in samples from dogs in their practice of the ticks that they'd removed, up to, I think, a half a dozen ticks from any one dog. And you can see that the ticks were sent in from all over the country by different veterinary practices. And it came up with some pretty interesting data, including the prevalence of ticks by region. You can see, obviously, the Highlands of Scotland very strongly presented, and of course, the New Forest and Thetford Forest out in Norfolk and Suffolk. But actually look at that all the way down through the West Country, right the way to Cornwall. Really quite high densities of ticks were identified. And these were the kind of ticks, not the stuff that's in the American literature, different species, especially the Ixodes ricinus, which is the sheep tick. And you can see the distribution there from where the ticks were recovered from. So one morning, this same child, who's now 4 years old, has got a nymph attached, which had probably been attached overnight. It didn't seem to be engorged, and her mum removed it with tick tweezers. But 3 days later, she develops a fever. She's mildly runny nose and got a slightly hoarse cry. And her mum rang me to say, what tests can we do? How can we tell whether this is Lyme disease again? And I'm afraid to say the short answer is you can't do anything, because if you repeat the antibody tests, they will still be positive. You know, she had a very good seroconversion illness, and it's almost certain that she would still be testing positive by antibody. And there really are no easy alternatives. You know, culturing the spirochete is difficult. It requires specialist laboratory facilities, and it's got a very low sensitivity. Interestingly, PCR testing, which is so useful for many other infectious diseases, is not much use if, you know, unless you can get fluid from a joint that's involved, or take a biopsy from the skin rash. You're very unlikely to actually be able to amplify the spirochete DNA. And so, and although there are some cellular immune assays, there's some studies in the Netherlands that's really suggested that these are not particularly helpful either. So frankly, you just have to think carefully about the differential diagnosis. And of course, back in May of 2021, it was much more likely this was COVID than it was a recurrence of Lyme disease. But you know, you have to think about whether this fits anything else, and if you're really convinced that this is another manifestation of Lyme, then obviously you may need to retreat. Oh, sorry, there you are. Is there a diagnostic test? No. Again, which comes back to the need for better science. Now, this is a lovely story. So, and it dates back to this time last year. It was actually April last year when I got the call from the parents. But this 2-year-old, case A, the parents lived in London, and on the 26th of February last year, they had, as a family, taken advantage of the glorious warm weather that we had, and were in Richmond Park, and endearingly, they described this child as feral, and he spent the afternoon desperately trying to get as close as he possibly could to the deer who were really trying very hard to keep away from him. And he was crawling around in the undergrowth. And they noticed actually that night a bit of a scratch over his ear, but there was no tick that they noticed. I mean, they didn't even think about that and didn't think more of it. But then about 3 weeks later, he developed some redness around the ear, just behind the ear and above the ear, and it gradually was spreading. And it got to this point here. I'm just going to play the video that the mother made at that point. So this is now 4 or 5 weeks after.
Keep turning so Ella can do your hair.
Can you see there's a faint rash on the neck?
Yeah.
And there's this rash that's now spread to the front of his face.
Oh, head back, head up. Head up.
Back. Yes, nicely.
Yeah,
I don't know how convincing that is,
lovely.
but that is a pretty strange rash. And they'd seen about 2 or 3 GPs by this stage and been treated with topical steroids, and because maybe it was eczema, and somebody thought maybe it was ringworm, but it doesn't look a bit like ringworm. It hasn't got an active leading edge in the same way that ringworm lesions do, and clearly everybody's a bit flummoxed. And the parents had a friend who was a pediatrician down in Kent who said to them, do you think this could be Lyme disease? And they went along to the emergency department and had some tests done, and lo and behold, the tests came back positive for Lyme disease, and I was consulted, and this child actually responded very well to 21 days of high-dose amoxicillin, and I haven't heard anything more recently, so I take it that all is well. But so interesting, because for me, this child had not read the textbooks. You're not supposed to get Lyme disease in February. And so I started talking to my colleagues at Porton Down, a very, very lovely colleague called Dr. Medlock, who does a lot of the entomology research there. And he was involved in this study, which is a nationwide study of the different species of Borrelia burgdorferi, a 6-year snapshot that was published in 2021. And the interesting thing here is the species that we are isolating reflect European experience with Guarini and Miyamotoi and other other Borrelia species that you do not read much about in the American literature. And the literature is very dominated by American case series. So we do need to be looking to European publications to really see what we're more likely to be experiencing in the UK. And Dr. Medlock told me that because they do these drag surveys every spring and actually once a month around Porton Down, and the tick densities in February 21 were twice the average for previous Februaries, based on a lot of data. And he'd also shared with me that the recent survey from nymphs recovered from ticks in Richmond Park, that 8% of the nymphs were infected with B. burgdorferi species. So, I mean, if you're a betting person and you get a nymph attached or a tick attached, it's probably not going to have any recognizable tick-borne infection. But nevertheless, it really does exist.